All right, this is going to be a longer vlog than normal, and it's going to be more technical than normal. And since we're going to need so much time, I thought I'd start early. So, we've decided that the first thing we're going to do is feed the midbrain to get the midbrain to work right. And then, of course, the first objection is always, well, we can't feed the midbrain because drugs feed the midbrain. And drugs are bad, and it would be bad to feed the midbrain. Don't raise dopamine, drugs raise dopamine. Dopamine, bad. Well, they've kind of got a point. Drugs do raise dopamine, very fast, very far, and for a very, very short time. Taking a drug is like eating a candy bar. Well, I guess for some people, eating a candy bar is taking a drug, but that's another issue. The opposite of eating a candy bar is not starvation. The opposite of eating a candy bar is a good diet. I'm not talking about feeding candy bars to the midbrain. I'm talking about feeding it a good diet. There's a difference between a spike of dopamine that you get from a drug and dopamine tone. Tone isn't bad. Tone is good. When there's not enough dopamine tone, spiking is actually worse. So the first thing you need to know is if you really want dopamine spiking to be less, then you have to increase dopamine tone. There's one specific genetic reason not to do this in some people, very few people. We'll talk about that later. And that's why one of the reasons we do genetic testing in people is to personalize this. But we'll get to that later. Most people, the rule is if you want to decrease dopamine spiking, you increase dopamine tone. So, what is the dopamine tone? We have to understand that first. Dopamine tone has three parts that make it up. First, there's the amount of dopamine released on a moment-to-moment basis. Second, there's the amount of dopamine, the amount and function of the dopamine receptors. And then thirdly, there's the amount of time that the dopamine that is released is there and available for the receptors. Those three factors are what gives you dopamine tone. And if you lower one of those factors, you will lower your dopamine tone. If you raise one of those factors, you will raise the dopamine tone. If one of those factors is lowered and you raise another, you will raise the dopamine tone back up. So these things don't compete, they all work together. Think of it like an equation where the total is the product of three things multiplied with each other. 1 times 2 times 3, for instance. If you change the 1 to a 2, the total goes up. 2 times 2 times 3. If you then change the second 2 to a 1, 2 times 1 times 3, it goes back to where it started. And if it was 1 times 1 times 3, and you raise the first one to a 2 instead of the second one, it's still that original product. So, think of tone that way. Now, the amount of dopamine released actually has a whole bunch of different factors. You can't release what you haven't produced. So dopamine production is a part of how much dopamine is released. And then the releasing process is a little complex. You release dopamine by releasing vesicles of dopamine, little balloons filled with dopamine molecules. And the dopamine release total is determined by the number of vesicles released per second times the amount of dopamine in each vesicle. And so You could have low dopamine release because you don't release enough vesicles, or you could have low dopamine release because your vesicles don't have enough dopamine in them. Now, the time is affected by two factors. And luckily here, really only one of them matters. The two factors are the enzymes that break down the dopamine in between the cells when it's released and it's trying to act on the receptors. And two, there's a vacuum cleaner, a reuptake pump, that takes the dopamine back up to the cell that released it at some certain rate. Well, the good news is that that enzyme is only about 10% of ending the dopamine signal, and so we really don't have to pay much attention to it. Again, except in very special people, and we're going to keep this on the majority case right now. We also said that in dopamine tone, you have the number and function of dopamine receptors. We're going to talk about that in the next episode. So in this rest of this episode, we're going to mostly talk about how to affect dopamine tone by affecting dopamine release or affecting the amount of time that the dopamine is there at the receptor. So back to dopamine tone. Remember that you can't release what you haven't made. So the first thing we have to look at is dopamine production. So you can't release what you haven't made. So there are some people who have a genetic problem that means they can't make as much dopamine. Now, the system for making dopamine requires a form of folic acid, the same folic acid in your diet, but a very specific form of folic acid called L-methylfolate. Now, L-methylfolate you can't get from leafy green vegetables. You get folate, and you have to make L-methylfolate. So the definition of a vitamin is something you can't make, that you have to eat in your diet. That's the definition of a vitamin. And folate is something you can't make. You have to get it in your diet, and that's why we call it a vitamin. But L-methylfolate, technically, is not a vitamin because you make it. Well, in certain people, they can't make it enough because of a mutation of an enzyme that turns folate into L-methylfolate. That enzyme is called methylene tetrahydrofolate reductase, and the abbreviation is MTHFR. And if you think about that abbreviation for a minute, you might realize what it's like to have this mutation. So you don't make enough dopamine because you eat all the leafy green vegetables you can. You get all the folate, but you don't have enough L-methylfolate, and therefore you don't make enough dopamine. And life isn't good. The great thing is, we can take L-methylfolate. Just like we could take a folate supplement, we can take an L-methylfolate supplement. And in that case, because the person doesn't make enough L-methylfolate, then L-methylfolate for them is relatively a vitamin. They don't make enough of it, and they have to take a supplement. So we could give somebody who has this mutation and doesn't make enough dopamine, we could give them L-methylfolate, and they would make enough dopamine. Now that you've made enough dopamine, you have to release enough dopamine. So there are two big receptors that cause, at least two that we know of, there are probably more, but two that we know of that we know how to affect. You gotta remember, about 5 or 10 years, all this is gonna seem silly and elementary, and we're gonna have a much more sophisticated view of this, I hope. So these two are the opioid receptor and the nicotine receptor. So let's say you have a mutation of your opioid receptor. It doesn't see your own brain's endorphin, and so it doesn't release dopamine on a normal basis, and you have a low dopamine tone. Well, somebody comes along and gives you an opioid, and big spike, right? We could give what's called a partial agonist, a partial turner on of that receptor that doesn't cause such a high spike. That and it lasted a very long time. So that would be something that could go to that receptor that has the mutation and cause it to act more normally and give the person a better dopamine release. Not in the way of heroin or OxyContin, where they get a big spike, but slowly, over time, over hours, returning the dopamine release to normal. And they'd feel normal, but not high. And because they're not high, there's no crash. That is buprenorphine. And that's why people use buprenorphine in some patients. Now, we also use buprenorphine for opioid withdrawal, which means a lot of people get started on it only because they were on opioids and not because they need it long term as the best medicine for addiction. So we really need to be able to concentrate on short term versus long term, and we'll talk about changing medicines a little bit later. Now, the other receptor is the nicotine receptor. And there's some evidence to suggest that the nicotine receptor and the opioid receptor are sitting very close to each other, and that maybe affecting one actually affects the other. But there's just some evidence of that. It's not known for sure. So we have the same kind of thing as buprenorphine for the opioid receptor. We have that for the nicotine receptor. It's a chemical called varenicline. It doesn't last as long as buprenorphine does. You actually have to take it twice a day instead of once a day. But it is a partial agonist and causes a trickling release of dopamine instead of a big spike and crash like nicotine does. And you might have heard of that medicine called Chantix, very common anti-smoking medicine. But the really cool thing about addiction medicines is that addiction's addiction. And if you're using amphetamines because you don't make enough, because you don't release enough dopamine, because you have a mutation at the nicotine receptor, or you're smoking for the same reason, taking varenicline will fix the original cause. Whatever the effect behavior is of that cause will get better. And so that points us to a problem we have currently in our approval of medicines for addictions. We focus on the effect instead of the cause, and that's never a smart thing if you're trying to fix a problem. Anyway, that was a parenthesis. Back to the original point. So either one of those medicines could be used to increase dopamine release. Now, both of those medicines affect the release of vesicles per second. But there's also a way to change the amount of dopamine in each vesicle. So when the dopamine is taken back up with that vacuum cleaner I mentioned, that I'll tell you more about in a minute, when the vacuum cleaner takes up the dopamine has to go all the way through the cytoplasm of the cell to where it gets repackaged in vesicles. That's a problem, because there's another enzyme that is sitting there waiting for it that breaks it down. And if that other enzyme, called monoamine oxidase B, is mutated to a way that it actually works stronger and better and faster than it's supposed to, then you make the dopamine, you take it back up, and your vesicles just sort of never get enough of it to be full. Well, there's several medicines we could use to block monoamine oxidase B and slow that metabolism so that more dopamine ends up back in the vesicles, and that increases dopamine release too. Now, I should say one more thing about a medicine that can cause dopamine release increase, and it's one we never use in addiction treatment, because everything we've told you about so far changes something that's not working right to return dopamine release to normal. Well, now I want to tell you about a medicine we don't use because it increases dopamine release, but in a way that's not normal, and so will have long-term negative effects. And that's an amphetamine. So the vacuum cleaner can actually be run in reverse if you take an amphetamine. And that means that the dopamine in the cytoplasm can get expelled and shoved out of the cell and over to where the receptors are. And you feel better. But you never ever retake up your dopamine. So you never restore the cell's amount of dopamine. And that's not good in the long run. You end up having to increase the dose over time, over years, and eventually you'll be in a spot where you can't take anymore because of toxicity, and it's a mess. Or you can only give the person the amphetamine part of the day or for only a few days at a time, and then give them what's called a drug holiday. And the problem with that is that if you have addiction and someone drops your dopamine tone by giving you a drug holiday, then you're going to go looking for a new drug. And that's not a good idea for addiction treatment. Well, time for breakfast. I'll come back with the rest of this in a minute. Nutritional interlude. See? A nice healthy breakfast. No candy for me. Okay, good breakfast. Thanks for waiting. So, we were talking about amphetamines and why we don't use them in addiction treatment. The reason is because they kind of leave us with a bad choice. You either treat 24/7, in which case you deplete the natural system, or you use what are called drug holidays, and you have falling dopamine. And I guess in a fifth grader, nobody really cares if his dopamine falls after 3. But you know, adults with addiction, it makes a big difference. So now, we've talked about the concept of dopamine tone. We've talked about dopamine production, dopamine release. And now, we want to talk about time. So remember that we said the time is just as important as the dopamine release is in dopamine tone. So the time is mostly affected not by the enzyme that's in the synapse between the cells, but by the reuptake pump. And you can genetically have a reuptake pump that just works too good, so that you release normal amounts of dopamine, and the next thing you know, there's none at the receptor because it's all gotten sucked back up before it can do anything, or it's not at the receptor long enough. Just basically the signal doesn't go through. Well, we could give a long-acting medication that blocks that receptor. Blocks the reuptake pump. Not runs it in reverse like an amphetamine, but just blocks it. Now that medicine is called bupropion, or Wellbutrin, and it comes in a bunch of forms. The original form of Wellbutrin scared a lot of people because it went from 0 to 60 in an hour. So an hour after you took the medicine, you were at the peak blood level. The next form that came out was SR. 3 hours after you took the medicine, you were at the peak blood level. And then they came out with XL. 5 hours after you take the medicine, you're at peak blood level. Well, even with XL, some people need to take it twice a day. With the original form that peaked in an hour, some people had seizures because dopamine was going up too fast. And some people with addiction get triggered because dopamine's going up too fast and it causes a peak and a crash. But with XL or any other long-acting form of a reuptake channel blocker, you don't get that. And so they are safe to use in people with addiction. A couple of things about that. One is that people will complain, some people will complain it doesn't work. And those are people who don't release enough dopamine. If you're not releasing enough dopamine, then blocking the reuptake pump doesn't really do anything. There's nothing there to block the reuptake of. And then you get nervous because it not only blocks the reuptake of dopamine, but it blocks the reuptake of norepinephrine, which is the brain's adrenaline. And so it'll work there, and you get extra adrenaline and anxiety and no dopamine. So a lot of people who treat addiction, who tried using Wellbutrin, got the sense it didn't work because they tried it in some of the wrong people. It doesn't work when you don't have good release already. So you have to ensure that someone has normal production and release before you try using that technique to raise dopamine tone. So we've covered the different spots where we can use medication to raise dopamine tone. Two more things I want to cover today. One is some general principles of medicine when you do this. And two is what are we going to do about the receptors? And that'll segue into the next episode. So first, some general principles. The first principle is you want to use the most specific agent that repairs or returns to near normal the specific problem that that patient has. So just about anybody who has low dopamine tone, who takes amphetamine, will have a higher dopamine tone, even if they don't produce enough. It'll work for a little while, which is why everybody thinks it's such a good treatment, because everybody feels better for a little while. But for a chronic disease, it's not a good idea. You want to change not the effect, not the end result. You want to change the cause and let the end result change itself. So this is why we started using genetic testing, looking for the specific targets that can lead to low dopamine and tell us better what medication to use. Now, before we had the genetic testing, we used our neurobiological model to predict, and we were right most of the time, but most of the doctors who have been doing the genetic testing at my old place said that the genetic testing helped in about a third of the cases, that they could guess right in 2/3 of the cases, but in about a third of the cases they never would have imagined that to try the medicine indicated by the genetic testing. So that's a pretty good thing, a third. Now, another basic principle of using medicine to affect somebody's tone is that we want to use long-acting medicines. So the specific one, we've talked about how to get there, but also long-acting. If you could take a medicine for a month, that's much better than taking a medicine every day. If you could take 1 dose a day, that's much better than taking 3 doses a day or even 2 doses a day. So you want to use the longest acting because you're looking for tone, which ought to be a flat line. We're not trying to make it go up and down in peaks like a wave. We're trying to make it go up slowly and like the tide. So you want a long-lasting medicine, something that'll at least last a whole day if you can get it. There are some cases we don't have medicines that you could take once a day, like Chantix. You have to take it twice a day. But people are developing new medicines all the time. And this might be a little political aside, but one of the reasons we don't get more medicines for addiction faster is because everybody is seeing all these addiction manifestations as separate addictions. And the FDA is required by law to only approve medicines for a diagnosis. And there's no such thing as a diagnosis of addiction. There's only a diagnosis of nicotine use disorder and cocaine use disorder and alcohol use disorder, etc. And so they can't actually approve a medicine for dopamine reuptake blockade in addiction, because you'd have to test it in 12 different diagnoses and have it approved separately for 12 different diagnoses. And so we get this confusing picture, and it ends up costing way too much money to make a new medication. And nobody's interested in like a Wellbutrin patch or a Chantix patch or something like that. That would be better. You know, you could take it once a day, or a gel that you could rub on, or that gets around the allergic to the adhesive problem of a patch, or some once a month subcutaneous injection. People aren't working on those things for any of the medicines except right now buprenorphine. And that's because there's enough money and enough demand for that one medicine that the drug companies can afford to do it. Well, there would be enough demand if the FDA would be able to entertain approving medications for a biological event like reuptake blockade rather than a diagnosis like cocaine use disorder. All right, so we covered feeding the midbrain. We covered feeding it tonically instead of phasically. We don't want ups and downs. We talked about the very specific ways we could do that. We talked about why we need to know the specific ways and why we want to use a longer acting, slower onset medicine if we could get one. And those are the general principles. And now that leaves us with how else we're going to affect dopamine tone at the receptor. We do not have a medicine that can increase the function or number of dopamine receptors. And I wish we did, but we don't. We do, however, have ways we can do it, and we'll talk about those next time. Have a great day.